Dr. Dempsey is Manucher Javid Professor and Chairman of Neurological Surgery at the University of Wisconsin School of Medicine and Public Health. He specializes in cranial neurosurgery, and he has extensive experience in neurosurgical management of brain tumors, cerebrovascular neurosurgery, and microvascular decompression. Dr. Dempsey is an internationally recognized expert in neurosurgical education and expanding global neurosurgical care. Currently, Dr. Dempsey has multiple NIH-funded research projects with a focus on cerebral ischemia and the repair of the injured brain. He has published more than 300 scientific articles on the subject, and he has been principal investigator of grants from National Institute of Health, Veterans Administration, and the American Heart Association, leading a group of neurosurgeons and scientists dedicated to improving patient care. We're excited for his talk today on neurosurgery's role in cerebrovascular global health. Dr. Dempsey, thank you for joining us today, and we're excited for your talk.
Well, thank you. Thank you so very much. Let me share screen. And let's see how we did there. I have to get to there. Okay, is everybody able to see my screen there?
Yes.
Thank you. Okay, well, I want to thank you very much for allowing me to be here to speak today. I'm honored and very much enjoyable. I was telling earlier that I have a son in Seattle, so it's near and dear to me, and we get to visit about twice a year to see people there. My topic today really can be summarized in the statement that I believe that neurosurgery must be involved in the teaching, the management, and the future of cerebrovascular care worldwide. And to say that strong a statement, I need to introduce to you this concept of global health and what that means. Some understanding of the complexity that we have in our cerebrovascular care in our centers in the United States, and the difference between what's available for the massive number of people who need it worldwide, and solutions which have to be based on teaching. So while I'm in danger of giving away my whole talk, I want to start by just introducing this concept of global health and trying to give you an idea of how important cerebral vascular will be in that concept. Because right now, we cannot have more clear ideas than how global we become. Our economy is global, our health is global, pandemics, warfare, faiths, health, all of these come together until you find these issues of values, peace, health, and family worldwide, each playing a role, and they all support each other. If one fails, it all fails. You've seen this right now with sort of difficulties about questions about who's responsible for global health, difficulties about the impact of a pandemic on world health and world economy at the same time, and indeed warfare. And you begin to understand that you have to probably learn a little bit about myself. I am a product of the post-World War II bustle of Chicago. I came from a phenomenal family where my parents raised us to believe in each other, to care for each other, and to do the very best we can with whatever gifts we might have. That's been very important to me, but it was a very blue collar, very rough and tumble background. We fought, we played, we stayed together. But this strange thing happened to me and to my brothers and sisters. They're called scholarships. And we ended up going from terrible education of my childhood. I literally attended one school with my brother where we thought crime and punishment were career opportunities as opposed to literature. But I was the winner of some scholarships, and my education changed, and the world opened up to me. And that was very important, and that's where family became important and where purpose in life became important to me. I began to understand the importance of healthcare I was very much a blue collar worker. I worked my way through school driving a forklift. I built houses, things like that. And at one time, I was on a project, a charity project, humanities project, building houses in Appalachia. And I met people there that, had purpose to their life in this very rural area. And this carpenter here, the man on the left, trying to point to, was the greatest carpenter I'd ever seen. And he had joy in his life. He would literally do it for nothing. He would teach people how to do things. And I thought, I get it. You don't have to be a brain surgeon to have purpose or fulfillment as long as you're doing something with and for people in the for their benefit. And then do it very, very well and be proud of it. I also kept my eyes open at that time, and I saw this tremendous healthcare needs in those areas of Appalachia in the United States. This is the stroke belt, and stroke became an important issue even early then. Years later, and multiple scholarships later, I was a neurosurgeon, and I was doing research on stroke, and I was working in Appalachia. Uh, and I would drive almost 10,000 miles a year, seeing patients in clinics in Eastern Kentucky, and then bringing them back to the University Center for their surgeries. And it became really sort of the start of this. But I also began to understand that I was sort of a drop in the bucket compared to the need, but I was a start. And what I saw was that over time that I began to be exposed to the needs worldwide. I mean, we all know about disparities in healthcare. We all know about the availability of what we do, and it might be limited. And I was taught that global health was something that had to do with infectious disease and cholera. Well, that was true, but quite inadequate. If you look at this need, you have 27 countries without one neurosurgeon, and you have even greater maldistribution of care where there might be a neurosurgeon in the capital, but no one in the rest of the country. So facilities that I might have and facilities you might see in a developing country. And so when you have that maldistribution of a specialty care, like our specialty, and I'm talking the full range of it, you suddenly, find that surgery is as important as infectious disease in their healthcare. Because when you get down to less than one neurosurgeon per million people, that collapses their trauma system. That means they can't take care of congenital CNS defects in children. They can't take care of benign tumors where its treatment could return people to active health care, active life, tax-paying work, pediatric care, brain care, and most importantly, to this conversation, cerebrovascular or stroke care. The needs are great, and the supply is very poor. I learned the approaches to this when I tried to go and take care of patients in Guatemala. This was my first real international trip. And it was a tremendous time of fulfillment for me. I saw all this need. I jumped in. I started taking care of 100 patients a day. What could I do? I'll do that. I'll be a general doctor. I'll be a surgeon. What do you need? But the impact on the people was only the ones I could touch. There were 11 million people. I was one doctor. And I learned a couple other important things. I was working in the rural area during the Civil War. This guy here has just stuck his M1 rifle through my clinic window to try to threaten me. The nurses shoot him away, but I learned that in Civil War, in warfare, I couldn't really provide health care. We see Band-Aid sort of things going on, but to really affect everyone, I need a stable government, stable families, some economy, because without food and medical practice, it wouldn't happen. But I did keep my eyes wide open. And over on the right is a child that I saw, took a picture of, and said, she's perfectly healthy. I'm in this village today. I won't be next week. Who's going to take care of her when she gets sick? And that was the day, decades and decades ago, that I started to train doctors. And that began to be something that I could do. I went to Ecuador because I was invited there by their local doctors. I listened, which was really new for doctors, if you think about it, specialists, to actually listen to the patient, listen to the people. What were their needs? And they said, well, we have a rudimentary health system. We don't have any specialty care. Could you train us? And I said, sure, that's what I do. So I began to teach. And I involved the Ecuadorian doctors in the programs until they took them over. And I realized it wasn't about me, it was about them. And when that mindset changed, they took ownership for their care because a teacher wants to be surpassed by their students. You don't want to turn out students that are lesser than you. You want them to use the techniques of their times to surpass the work of your time. And so we did. And I learned and went back and I learned that the issues were solved by continually being present, going. And that became far easier as electronic communication made it easier. But you listen, you don't assume you know what people want, and then you teach. And if you stop and think about that, that's exactly what you're supposed to be doing to your patients now in Seattle. You're supposed to be there for them. You're supposed to listen. Don't assume you know. And they will talk to you non-verbally, how they walk, how their posture, what their mood is, what they're saying. And you teach them about their disease, their issues, until they can take over their care. You'll assist by doing your surgery, but their recovery is basically on them. We also learned that they needed equipment, but it wasn't as complex as I thought. And I also learned the importance of my own family because I took them and they taught me. They were my eyes and ears. They were the ones that taught me how to clean instruments. This is my wife. They're the ones that, as they grew up, this is my daughter marveling at the glove drying rack in Ecuador, which we would reuse the gloves. And she would be the interface with the middle class, with the people. She would be the one that would earn their trust and then come running to tell us this was a need, this is what they said. Because there are always challenges. Global health is full of challenges, but we're neurosurgeons. That's what we do every day. You know, the power goes out, the volunteers get sick, the government gets overthrown. Or my favorite, this is the volcano outside the hospital in Ambato, Ecuador. Tungurahua was perfectly quiet and snow-capped earlier. And when you finish the case, you ask how are the post-ops? They say, well, they're fine, but the volcano's erupting. But don't worry, we think the lava will probably flow in the other direction. So global health taught me a lot of things that I wasn't prepared for. And I learned a lot about myself. And I learned about things that I could do, which were teach, and things I couldn't do, which is take care of everyone. But if I taught, maybe they could. But I needed that stable government. I needed a helpful army. I needed peace, and I needed them to have food. And so we began to teach, and it became a wonderful thing. These students have basically traveled across the country because they knew I'd be there to lecture, to talk. These doctors knew how to do basic neurosurgery, but needed to raise their game. And these doctors needed to take over the program as we became superfluous and they began to just need help with curriculum or certification. And that's exactly what happened. And it's a marvelous thing because it teaches you that it's not about you, it's about the patients being served. That's what global health is. Of this time, I became known to this group called the Foundation for International Education in Neurological Surgery, or FIENS. Now, this, in my opinion, is the major philanthropic or humanitarian group of all neurosurgery. It has been present for approximately 56 years, and it has been working with neurosurgical volunteers to meet global neurosurgical need worldwide until it becomes self-sustaining. Educational programs which we may help them start in various countries, and then they grow till they become self-sustaining, and people of that country run and teach people of that country till we can get them this curriculum, the certification, the equipment, and the postgraduate education. And that program was very interesting to me. I'm the one that took it from just going to do care to going to teach. And I have to be careful when you do something like that because they put me in charge of it. So I now chair the foundation. And our big project was in East Sub-Saharan Africa. In the year 2000, there were 400 million people in this area, which you would call East Sub-Saharan Africa. No neurosurgical training whatsoever. Minimum number of people who had done apprenticeships, maybe in Europe or Asia, and then came back to their home area with various levels of success. You might have 2 successful surgeons in a country of 35 million, something like that. And that was it. And they were basically struggling to be a force in healthcare in that country when the ministers of health basically thought they were treating malaria and AIDS, and that would be it. So I began to get involved, and I began to talk to ministers of health, and I began to go. And the same lessons applied. Be present, get the local support, the middle class, the government. And I would make a deal with them that if they would fund the residency, we would provide the curriculum and enough equipment to get it started. And we'd do it right there in their capital, in their major charity hospital. And it would be their program, but we would support it. And that usually worked. And some of these people are now leaders in neurosurgical care throughout Africa. And that's phenomenal. And we learned lots. In Kenya, we learned that as the population had collapsed on the capital, which is very common in many countries throughout the world, all healthcare collapsed there, meaning all the major cities, 4 million people here, 2 million people here, etc., had nothing. No trauma service, no cancer, no stroke service. So we began to do outreach clinics in these major population centers monthly. So we would train the nurses, get the local hospital prepared, do some cases there. So graduates of the program in Nairobi could be sited in those sites. Because previously, when we arrived, there was one hospital that did neurosurgery in the entire country. And that was the major charity hospital. And it had 3,000 beds and 5,000 patients. So do the math, it's not going to work. The average person in Mombasa who had a benign brain tumor that could be cured would sell their store, sell their farm, move to Nairobi, sit under the jacaranda tree, and hope that they would win the lottery and be operated on by the 2 good surgeons in the country. It was impossible odds. But as we began to train people in Nairobi and the surrounding countries, we would then cite the graduates in and support them in these other cities with the great benefit and help of the government who would support these because it changed their trauma system. It could change their stroke care. It could change their tumor care, their pain care, or importantly, their care of congenital anomalies of children. And we learned lots of things. Very small things can make a huge impact. I've learned to operate with much less equipment. And, people here wonder, why do you never lose any blood? Well, there's no blood to give in Africa. So you better have techniques that are very, very good. And yet some small things, this is the first microscope, me teaching the first aneurysm clipping in that region. And it changes. Now they're totally independent on that. And that really taught me that we could teach cerebrovascular neurosurgery. It did not have to be subdurals and shunts. And that would be important because we needed to take a leadership role with this disease called stroke, which I knew so much about in the States, yet was not considered to be common in the developing world, mainly because people died very young. Well, that's changing rapidly. And we know now that stroke will be the #1 cause of death and disability in the developing world in this next decade. It will surpass infection. And that's just the way society has changed. And so those ideas began to spread. We went to Tanzania. We developed this concept of dyads where we would partner one program, say Duke, with a country or with a hospital, Columbia with one, Wisconsin with another, and on and on. And suddenly we had hundreds and even thousands of trainees where we used to have none. And that means millions of patients to be served. There's much more to be done, but this is the day that the president of Tanzania promised 15% of his budget to go toward healthcare. And he was good to his word. New hospital, new neurosurgical hospital, new neurosurgical equipment that I had to set up for them. That's more than I can get out of our government here. So we have to understand that that partnership is essential. And that's true about today. We have to partner with our own government and local governments, national and local, for the good of the people we serve. It spread like wildfire. This idea suddenly was in Zambia. It was in Zanzibar. It was in Uganda, Ecuador, Zimbabwe, Haiti, Myanmar, Bolivia, on and on. And neurosurgeons jumped on and said, I can do this. Can you give us the curriculum, the certification? And that's what FIENS does. This is, and it's an international program. This is a truly neurosurgical hospital built by the Spanish neurosurgeons to care for the people of Zanzibar, where there was nothing before. And now they're a major hub for us as far as the trainee sites. And then a very important thing happened, science. The Lancet Commission looked at this issue of what is the real need in global health. And they discovered that 5 billion people, billion with a B, lacked access to life-saving surgery. That means us. And that means that absent that, we have 140 million lives or families decimated, 47 million unnecessary deaths. I mean, that's more than war. That's more than COVID, because they couldn't get to a surgeon that could have saved their life and returned them to active. Now, neurosurgery is about 15 to 20% of that, especially in the trauma world, but that's really important. And the World Health Organization, every single country in the world, that never happens, declared, let's focus on health with surgical, because we don't have these people in access. And what can you do? Well, you could fly in Dempsey to every country in the world and expect them to do maybe 47 million operations. Not going to happen. You could take the smartest people from those countries, bring them to Berlin or London or Madison, Wisconsin, and expect them to be trained in neurosurgery and go back. There's no equipment there. There's no infrastructure. The only way you can make this work is you have to train them there. And you have to build and you have to sell their middle class and their government that this is of value. And who does that? Next thing I know, I'm on a plane to Geneva. And I said to them that I will be part of this objective to start surgery in the developing world if we will also do stroke. Because I told them it will decimate the developing world. They said, well, think about it. They thought about it, said, you're right, you're on both commissions. And so now we're with the Rockefeller grant starting Cerebrovascular. And I want to show you what's possible. Because one of the things that happens when you have ideas that make sense is it catch fire and good people jump on. We do postgraduate education here, why not there? All these trainees, we don't leave them and say good luck. We have to make sure that they're supported, that they can raise their families, that they'll stay in Mombasa or Kisumu or wherever the smaller city is. And so we started the same boot camps that we started in the United States in 2010 throughout. And in 2016, 2015, we started with the first one, which was in Bolivia, and it spread to Africa, Asia, China, Kenya, Vietnam, Nepal, Afghanistan. This is really substantial because ideas like this just catch fire and grow. And they do. And we meet some of the most phenomenal people because they teach you how to overcome challenges. They'll always be them. These are post-ops, and when the rain falls, they're in the rain. This is war. It is constant, and it undermines all educational possibilities. We need peace for that. And what about COVID? We thought we were done. We could not possibly continue to teach. But all of these young people said, keep going. We know more about uh, electronic communication than you ever will, Dr. Dempsey. We'll figure out this thing called Zoom, and you can keep teaching. And we did. And that became an integral part of our ongoing work. Because when we began to think about web-based conferences and teaching sessions, we began this twinning and postgraduate education. The major next step of what Foundation does is to continue to care for the doctors, the young doctors we train, until they take over this concept of global health. And that brings us to cerebrovascular care. I've introduced this concept as really the poor stepchild of global health. We have said, gee, we can't do that. It's too expensive. Well, I never believe what people tell me about things like that. This is where the patient need is going to be and is now throughout the world. Untreated millions of patients, and they're going to become more and more prevalent as infection becomes less of an issue and people live longer throughout the world. So I believe that's something we must, as neurosurgeons, take the lead on. Second leading cause of death worldwide. Third leading disability. Millions of strokes per year, and probably way underestimated. We know that from COVID is that the number of people that had strokes was massively underreported. And the lifetime risk has increased greatly. And where the increase is in the low-income countries of the world. 90% of death and disability from stroke is in those low and middle-income countries. And the mortality and worse disability is 4 times higher. It is amazing, but not surprising. It has to do with, can we attack this just as we attack trauma, just as we attack infection, just as we attack all healthcare problems? We go to where the patient need is. And this is the future need. So let's think about what we do in the United States and say, how in the world could we possibly do that in a low-income country? Well, I think I can show you. Think about what we're doing. What is the state of the art? And the state of the art is constantly in flux. And that's a good thing because a lot of the early adopted technologies are still very expensive. But as we improve, they will become more mainstream and they will become more affordable. The medications, thrombectomy, have really changed what we do. It has made us alert to the fact that we can reverse strokes. When that was proven in 2015, it changed the world. We were literally standing on the chairs at the International Stroke Meeting, screaming with tears in our eyes, hugging each other because all of this work, all of the stroke centers, which were based previously on just this IV medications, which was remarkably poorly effective, were changed when we saw that surgical approaches to stroke could reverse 10 times as many successes. It meant everything. And it meant neurosurgery has to be involved. And you know far better than I how these techniques are changing, employed, and slowly working their way more intracranial, the smaller vessels, and remarkable stuff. I saw this coming and brought bioengineers into my department here in Madison just for the development of microcatheters, of delivery devices, of nanoparticle strategies to try to see, because those will be cost effective and those will change. Just look at what's changed in just your residence lifetime, much less ours. And traditional techniques still have a major role. Carotid endarterectomy is time proven, can be done very straightforward, is very effective. And as smoking rates increase in Asia, this is the disease that you're going to be treating there. And so having these techniques complemented by more modern techniques with balloons and stents, etc., and hybrid techniques of them, such as TCAR with flow reversal, make a lot of sense. And I firmly believe that while they may seem expensive now, they will not be. You know, shunts were impossible when I was to have access in the developing world. And now we have shunts that cost less than a bag of groceries. And that's really the way the world's coming. If we think, you know, we're doing lots of scientific studies to try to determine which are the best techniques. I'm watching them closely because I want to see what is the techniques that are going to make the most impact in the developing world. We learned long ago that that depends on being straightforward, being simple, minimizing equipment, and making use of reusable things, which can be done. These hybrid suites are wonderful. Can we simplify them or can we centralize them? Both techniques are being done and both make sense in different areas. One more complex for training and one much more straightforward for life-saving treatment in the smaller cities. Clipping will still play a major role, trapping, bypass, stents, coils, of course, because these are major problems. Although I want to help you realize, while we are fascinated by aneurysms, the real numbers are in ischemic disease or in the intracerebral hemorrhages. Prevention's important, but we need to be thinking about treatments that can, in those diseases, that can restore people to useful function. And indeed, aneurysm surgery can do that, of all kinds. So we're watching these, we're developing them, a lot of our bioengineers here, because some of these I think will be so straightforward and simple that they'll be well adopted even in regional centers in sub-Saharan Africa, not just the capitals. This continues on to the advancements in AVMs. What's the real problem in the low-income countries of the world? Well, tremendous changes in risk factors. As a matter of fact, going backwards on risk factors. I do studies with the Native Americans of the Americas on their risk factors and how that has changed as their diet has changed stroke rates, and what we can do to prevent. We're into basically an epidemic of bad risk factors in the low and middle income countries. We can change that, but because of that, ischemic stroke is rising, as is hypertensive. If you look at it, that's where the patients are. Probably 86% are in those low-income countries, and that's probably an underestimate because they're poorly reported. And I believe that we have to be very innovative about our surgical techniques, taking a leadership role, being the core of the stroke center for that country, which will then develop satellite centers, because these are underutilized in the low and middle income countries of the world and need not be. If you begin to look at the distribution of neurosurgical care, we've emphasized, of course, Haiti, and we've emphasized sub-Saharan Africa, but there is tremendous unmet need in Western Africa, in Central Asia. And so this past year, I've been working in Central Asia, trying to get a feel for that and to see how we can work with our partners there to develop these sorts of care centers throughout the world, really worldwide. We can't just go where we are most familiar. We have to go where the patients are. And the issues are important. Stroke care is timely. And this is just a graph of what percent of people can't get care within 2 hours. And that's really concerning in sub-Saharan Africa. We therefore have to bring the centers to the smaller cities. By smaller, I mean cities of 4 million, not just the 20 million in the capital. This is Latin America, East Asia. And you can see there are solvable problems, especially I think in Asia, where populations do tend to center near larger areas where we could cite regional centers. And that began, these sort of charts got me very interested in what could we do for regional care? Because we're trying to change a culture. This is one of my favorite pictures. This is in Haiti. The ventilator may stop working abruptly. I mean, when you're starting with that sort of a problem, you have to look big and long haul to try to get the training, the equipment, and simple equipment to access the greatest number of people. So again, the foundations begin to look at this. We're looking at dedicated care to become self-sustaining, and we're focusing on postgraduate education and where we would do that. Now, a lot of the education, it still takes place in the high-income countries. Why not develop high-income, low-income hybrids in the low-income countries so that volunteers can be doing their teaching in a safe place? And we do this by overcoming the challenges, including endovascular training, to retain neurosurgeons in their home countries, train the whole staff, and use the high income, low income twinning to be successful. This started with the boot camps. This was the first international boot camp, was in Bolivia, and it grew like wildfire. South Africa, Myanmar, Bolivia, Vietnam, and then regional training centers. This is the important next step because I believe we need to get care within 2 hours of people. And so it's a start, but this is what we did. We partnered with the American College of Surgeons to build in sub-Saharan Africa 3 regional training centers, staffed 12 months a year by various universities until this dyad became focused center of training for the region, hopefully for multiple countries. And so this would be for education, which would be certified by their regional areas, for research, because that gets you the brightest residents and the brightest trainees and the hope for the future, because they allow us to listen to what their problems are and their solutions, and then bring greater techniques, endoscopic, etc. And so 3 centers have been developed, Ethiopia, Zambia, and Rwanda, and they've been very successful. It's been the role model, which we're now doing in South America. And in South America, this is a training center just for neurosurgery, neurology. It's partnered with a lay organization and with 3 governments, Bolivia, Paraguay, and Uruguay. And it serves the entire central core of the less developed area of South America. And what it is built on these lessons learned from the other global health experiences, committed to improving care and doing through training. So the education is bi-directional. They have residents there. We have residents here. We began to link them electronically so that they would do virtual and then in-person training. These residents get to know each other through their monthly conferences supervised by the faculty. We developed microsurgical skill laboratories in those countries. And this doctor here on my staff, Abdullah, has really developed a technique to have people go through courses which they can do in their own country, as long as we can get the equipment to them. And we learned a lot about equipment in doing this. In-person and virtual courses, endoscopic, endovascular, microsurgical, why not? Raise the bar. So working with these partnerships, an initiative from 2019, we developed the resources, a lot from my university, and then the credits, and began these sessions. So translated in real time, evaluated with mandatory questions, attendance, presentations, the residents doing most of the teaching and learning by that, faculty supervising, and awards given to the most effective and most contributing residents from both services to travel to the other country, meet the people in person, come here for our simulation labs, go there to operate side by side with the staff there until they learn the techniques and learn to improve their skills by providing better care. The in-person boot camps have been very, very valuable, such as microsurgery course, and the travel where they come to Madison, we've gotten philanthropy to fund that. And then hands-on courses in spine, in endoscopic, in cerebrovascular, etc. The resources become real. We begin to find used equipment, repurposed equipment, or some new at better prices by partnering with the companies. But one of the things that was important for training, which was amazing, was that Abdullah was able to find high school dissection microscopes, which he would then revise so that you could practice microsurgical skills in a dissection laboratory, like the ones we have. So we began to develop dissection laboratories throughout the world linked by video feeds. So he could teach in real time and supervise and see what they are doing in Yemen or in Ethiopia. Research is being done. This is a tremendous source of research. How do we teach? How do we improve? And service is real. The doctors of Paraguay said, we're very good at lots of things, but not at cerebrovascular. We need to become cerebrovascular microsurgeons. I said, okay, we'll make that a topic of our virtual meetings. Then we'll start the microsurgical training virtually and in person supervise it. And then one of my ex-residents, Nirav Patel from Harvard, would go down there and work with you side by side on cases as you developed until you become independent. And that's exactly what's happened in that country, which had good neurosurgical care but no cerebrovascular, and now does. And the accomplishments just in 2023, 4 trips in person, 3 of them for courses, multiple conferences, publications, resident lectures, professional visits, multiple cases, and hundreds of people trained, and hospitals equipped with donated equipment. This is Abdullah's lab here in Madison. We've set him up with equipment which we begged, borrowed, and repurposed until that he can show a microsurgical technique on plastic or otherwise online, and people can watch worldwide, and then he can watch their work with, using iPad technology to be able to supervise what they do. So these courses have been worldwide, Lebanon, Turkey, Bangladesh, Paraguay. But the techniques include a course with a regular curriculum on starting with Penrose, then silicone, then chicken vessels, etc., till people develop microsurgical techniques, which are invaluable for everything they want to do on cerebrovascular neurosurgery. And this is all graded, supervised, and you can be halfway around the world because nobody comes to do a fellowship with us here from another country. We've had 360 people come to Madison for such 2 and 3 and even 12-month fellowships on microsurgery. And then they go back with a suitcase full of repurposed microscopes. And then they set them up and video feed us back and forth as to our work till their courses go on. This is an example of donations. People, we took this to Paraguay so they could practice, and they do hands-on training in their own place, supervised by video screens by Abdullah here. So might have 20 people there being supervised from Madison until they become more and more confident of their skills. And then we go down and start teaching in live surgery, such as AVMs. And it's worked. It's changed the way they can practice in a country. And it's amazing. This is a child with a ruptured AVM that is now normal. And the neurosurgeons there are comfortable. They can do these things. And this has gone to Bangladesh. It's gone really to now hundreds of trainees worldwide. Because what we're really learning is we can do this, we together. It's not about us, it's about the patients being served. We can go to where those patients are. There are good people there. And if we can have peace and we could have some stability, those trainees will stay there and the equipment can follow. But we can continue the education online and in person, and then have an exchange of trainees until they supplement what is virtual teaching in this most important area of our future. Because I believe that one of the major futures of neurosurgery is in cerebrovascular neurosurgery. And it involves us going to where the patients are and making sure our services, microsurgical, endovascular, preventive, and rehabilitative, are available worldwide. And if we succeed at that, we will succeed throughout because the programs will be taken over by the people of those countries. So I think we're at the cusp of a very great revolution in neurosurgery. Along with cerebrovascular will be restorative or regenerative neurosurgery, which will transform functional. So I have the scientist here working on those projects as well. And I think the future is in these young people that you see from every country, because that's really where we need to be teaching. So that's what I have today. And I think that cerebrovascular is really a phenomenal field and always has been. Thanks very much. I'd be glad to take any questions you have.
Yeah, thank you so much, Dr. Dempsey, for a great talk, and we'll open the floor to a question now.
Thanks, Dr. Dempsey. Steve Monteith, I'm a director of Cerebrovascular here at Swedish. That was a really inspirational a talk from you, and sort of demonstration of a calling and a life's work. And for our fellows and trainees, it's really just fascinating seeing how your whole career developed around this precious gift that you've given to all these people. I had a couple of questions. With regards to endovascular and open surgery, just wanted you to elaborate a little bit more on the challenges of clipping an aneurysm is maybe $100 for the clip. To coil an aneurysm, these days, or to use an endosaccular device and all the microcatheters at about $1,000 each, and all of that sort of thing. That's something I've always sort of wrestled with when it comes to cerebrovascular neurosurgery in the developing world. Should we just clip everything, or how do you do the calculus of training people to do endovascular in the developing world when you can do it for a fraction of the cost with the older techniques?
Well, the simple answer, Stephen, is that we can't get the clot out of the middle cerebral microvascularly. And if we don't develop our endovascular skills, we will lose the majority of the cerebrovascular patients. I mean, they will suffer from that. So we need to develop both techniques. I firmly believe we'll still be clipping aneurysms, but the distribution will change. But we need to develop both techniques. And the answer to this question you have is so very important. What I do is I take residents or students and I say, okay, you just ordered an MRI scan, stroke deluxe, how much does it cost? And they go, and they look it up, it's $15,000. I mean, when you think about the total cost and all the ways things, I said, okay, I ordered 2 scans a week apart. One was a stroke deluxe MRI here, and you probably ordered it, Q 15 minutes stroke deluxe MRI scan. Bing, 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 bing. Dollar signs are going up here. I ordered a scan that was everything I needed to save the baby's life. The difference was it was in Ambato, Ecuador, a week later. What do you think that cost? And they say, I don't know, $2,000, $1,000, $700. It cost me $25. Now, the difference was I was blackmailing the guy that owned the scanner, okay? Because I was very focused about saving that baby's life. But the true cost of these things is artificial. Let's admit it. And if my guys here, and that's why I hired them, can develop true, microcatheters that are either reusable or extremely inexpensive, and they will. It'll be like the shunts now. We have $25 shunts that have just revolutionized that. And most of the time we can do an endoscopic procedure, which eliminates the shunt. So I see the real future being in ischemic endovascular disease. And we may not be using biplane. We may be using, straightforward, find it, do it, pull it. That will rapidly cause people to demand, I need biplane. I want to put coils in now, the government support. And we're going to force the price of the stents down because we're going to say this is the stent. Right now, every stent is more and more expensive because it's the latest, greatest thing, and it's got to pay its development costs. As we begin to simplify, that's going to happen. It's going to happen during your career. I'm just trying to be prepared for it. There's no question that I can start with those regional center concepts, and that's where the first endovascular program is going to be. And if I can show the government its efficacy, it's gonna spread. I have to also make it cheaper, but we can. That's the lesson I learned just about my surgical, kit. It used to be, enormous. Now, a knife, fork, and spoon, I can do almost anything. And endovascular will do the same. I firmly believe it. I think that's far easier to simplify than some of the other things which have taken the lead. We now have endoscopic towers throughout Africa. It's just so, and who proved that was important? A neurosurgeon. My partner was Ben Worf. He went to Uganda and did the research there and proved that this tool could be simplified and change hydrocephalic care. And we adopted what he learned in Uganda in the US. Every third ventriculostomy your residents are doing, that's straight out of Mbali, Uganda. And, of course, he's at Harvard, but that's where it came from. So I believe we can do it. It's going to be generational, but it's going to work.
You raise an interesting point because you're absolutely right. The cost of a coil in India is not the same cost of a coil in Seattle, Washington, and it's the same coil.
Absolutely.
So that's interesting. Another question I had was your model where you're building these folks to be self-sustaining. Have you had any challenges where, we often hear criticisms of folks coming in from the West to train people, etc., and then they leave and it all kind of falls apart. Have you had any challenges or overcome obstacles where it looked like it was going to kind of roll over when you weren't there, and then how did you right the ship, or was the ship not able to be righted in some cases?
Well, both are true. I mean, the answers don't leave. This idea of being present is really important. It just changes from we'll teach you how to start a program to we'll teach you about postgraduate education now. And you're in charge of it, but here's this concept of a boot camp. That's really been the goal. Most of my life has been 3 steps forward and 2 back. Okay. You set up a program, it's really it's great. And the new El Presidente only wants doctors trained in Cuba. Okay. I have to leave for a while till the next Presidente comes in. That's happened. Zimbabwe, was terribly dangerous. And then I got a call saying from the young people of that country saying, we're going back because the dictator is very, very old and things are changing. We think we can do healthcare. Come help us set up a program. I went, lots of enthusiasm, lots of joy. The president died. The new dictator was worse. I had to pull out. Okay, it just wasn't safe. I can't have volunteer teachers where they might be kidnapped or etc. Right now, Afghanistan is the biggest problem after Haiti and Afghanistan because it's not safe for volunteers there. I have very, very brave people getting equipment into Afghanistan for the Afghani neurosurgeons that are still there working. We're just trying to keep them going. But invariably, the answer is be present and listen. They're not going to stay if they don't have the equipment. So we train them there with the equipment and gather it and get donations, etc., till their center is good. Then how do I get them established in the secondary city, say Mombasa? And do I send my volunteers now they're there to work with them side by side for 2 weeks every once in a while? That stimulates them. And it also shows the local people, it might be the bishop, the governor, the president, that this person's important. I have a lot of titles. If I go and say, this person's important, I've come halfway around the world, you take care of them and I will too, they often do. So it's the sort of thing that's worth it, but you are talking about the realities of life, that it is hard. If you bring them here without any infrastructure back home, they're not going back. If you show them the possibility of it working there, the government embraces it. I mean, that they build neurosurgical hospitals in some places just because it's a possibility. And if you can explain to them just how many diseases neurosurgeons take care of and how many patients are affected by that, it changes their whole outlook.
Yeah, and congratulations again. I mean, I think, you've showed a lot of these places what can be done. And I think that when you're starting at ground zero, it's hard to see how they could get there. But when you see the model that you've done around the world, you can see the end point and the end game. So you should be really proud of that.
Yeah, it helps to be very old. That means I've been trying it for a while. Been trying it. And I see Mark's there. Mark, how you doing?
Thank you, Dr. Dempsey, for the great talk. I really enjoyed it. The one question, of course, that I always bring up when talking about these different topics is, what's the proper allocation of resources in terms of preventative care versus acute care? I guess specifically when it comes to stroke. And does that change from country to country? Does that change through time with the development of a country?
It does not change. It is always primary, prevent disease. I mean, people say, what are you doing here? Unbeknownst to most people, I run the stroke prevention program in the highest stroke risk population in America. The highest stroke risk population in America is who? It's not African American. It's not migrant. It's not inner city. It is reservation-based Native Americans. We have 11 tribal nations in Wisconsin with the highest stroke risk in America. So 3 days a month, I drive up north and I run the program there. And it's their program, but they love seeing my Jeep come through the snow up there, and they say, he's here, then this must be important. We're gonna do this. And it took years, but the same rules were in effect, right? Be present and listen. Don't assume you know what they need, then they will tell you. You have to build trust by coming back. If you go and leave, it will fall apart. You're right, unless they really have become self-sustaining. I'm not happy till I see the person I trained graduating their trainees. And that's what's happening now in Africa. And that's why we need to do more in West Africa and Central Asia, because they got a long way to go there.
Dempsey, there's one note in the chat. We're getting very close to time here. A question asking what the model of the high school microscope that you use for training.
It's the one that you all used in high school for your dissection lab. It turns out that Abdullah can hotwire that with it doesn't matter the brand. You know, these are Welsh Allen mostly, but they're the same microscope. It's very simple, and believe me, I go and practice on those sometimes. You know, our dissection lab has all of the above, and we have the surgical scopes and so on. But if the trainees are using the surgical scope or the Zyscope, I'll use that and just practice. So I'm satisfied with what I'm going to do or where I'm going to place my hands tomorrow. And they're amazing, you know, for what we do, doing the non-inanimate objects, you know, or maybe the rat femorals or things like that. You really learn where your hands work, and it's a tremendous thing for people, and very easy to make the jump to the OR.
Yep. Good. Well, I think we're almost at time. We really appreciate you spending the time with us this morning. As I said, just a really inspirational talk, a life's work, just awesome to see, and amazing what you're doing throughout the world. We really appreciate you taking the time to talk to us and the people online.
Well, thank you. It's truly my honor. I really want to thank everybody. Wish you well, and you know, I hope to visit, as I said, one of the times I'm out there seeing my son. Take care now.
Let us know when you're here.
Bye.
Okay. Take care.
Bye.